Hello, it's Dr. Hammerstedt from Holist. I'm trying again here to get a pediatric emergency medicine specialist, Dr. Stacia Dearman, on here for us to talk about something that's really, really close to my heart, which is physician wellness. You know that me, Dr. Hammerstedt from Holist, I really am passionate about pulling physicians together so that we get to know each other, stop practicing in our silos, try to heal our health system from the inside. Because if you do not heal yourself as a physician, you are going to be unable to provide the care that you and your patients deserve for them to get. So I am going to bring her on here. Dr. Dearman, do you see a way to join when you touch? There we go. I'm adding you. So what Dr. Dearman does is she talks about physician wellness around a very specific topic, which is about the mitigation and emotional support of malpractice and litigation. And this is really important for all of us because it is something that we do not talk about much. And some of that is because I think we're afraid to talk about it if we've been sued. Some of us may be embarrassed. There also is, this added you can't talk about the details of a case. Hi,
Wow.
you did it. And we're next to each other and everything worked. Welcome.
Thank you.
I didn't even have to ramble too much. So nice work. You spared everyone that.
Excellent. Excellent. Good work at your end.
Yes. So welcome to Holist this morning for this Medical Monday. And I was just introducing you a little bit here, talking about, we're going to be talking about physician wellness around malpractice. And so you're a pediatrician, you are in Ohio. You have all sorts of things that you love to do for your own self-care. You've got a couple of older kids, I hear. And so you are a busy, busy woman, just like all the rest of us doctor moms.
Yeah.
So,
Yeah.
so tell us a little bit about your why, about why this is Thrive, why this is your passion, why you wanted to take on this topic for us.
Well, it comes from a very personal place. I practice in the environment of pediatric emergency medicine. I trained in general pediatrics, but about 5 years into my practice, transitioned into a pediatric ER environment and love it. That's where I've been for between 15 and 20 years. And about 6 years ago, I had a particularly painful and poignant situation arise in the course of my practice, in which I saw a young woman and took what I think was good care of her, sent her home at the end of the day, and the next day, very sadly, she arrested at home. Was taken by ambulance to a local emergency department close to her home and then flown to the hospital where I worked directly into the ICU. They were having some issues with airway management. Brought in an ENT to manage the airway. And then she spent 3 or 4 days in the ICU and ultimately was taken off of life support. As you and I know, a person who requires that degree of resuscitation often doesn't do very well, and she didn't. So that was a really, truly stunning experience for me. I had seen her on a Friday, gone home, returned to work at 5 p.m. on Saturday, and no sooner did I get there than the ENT came to my department. He was someone I knew well through the hospital, came to my department to let me know that this patient of mine was in the ICU. And it really was a stunning experience. I can't tell you just how very startled and stunned I felt. It really gave me the feeling I've had before when I've gotten one of those phone calls where I learned that someone I love has died, that sort of out of body feeling that many of us in that circumstance.
Yeah.
And so that was one piece of my experience that really took a long time for me to unravel. I suspected as soon as I knew what happened that I would probably be sued, and ultimately, about a year later, I was. Um, and the lawsuit unfolded over a period of about 2.5 years. I ultimately went to trial and spent 3 weeks in a courtroom,
Mm.
and found it to be quite possibly the single most difficult experience I've ever had. So
So,
along
so,
the way, yeah, go ahead.
so, how did, give us a little bit of statistics about how common this is, because I think one of the we don't, nobody talks about this, right? I mean, the fact that you're on here telling us this personal story, this is a very unique thing. So we don't talk about it, so we don't understand how often it happens. We don't know how to support each other, and I know that's the purpose of your Thrive. But so give us some tips, give us some stats.
All right, so no, you're exactly right. I talk about it precisely because we don't talk about it. And I have concluded that's very, very bad for us, bad
Yeah.
for our health in every way. So I litigation, I began to believe that I needed some way to make something beautiful out of this experience that was so very difficult. So as soon as my trial was over, I started to explore the subject, initially just thinking that I would look for a way to maybe give a presentation to my colleagues at work or start to teach residents. And in the course of exploring things, I stumbled on an article published in 2011 in the New England Journal of Medicine that I think is the best study I've found so far, giving us data around how many physicians are sued and in what specialties, how frequently, and so forth. And what I learned from that study is that in what they call the high risk specialties, which in this study are primarily surgical specialties, 99% of physicians will be sued before the age of 65. In the quote unquote low risk specialties, that's like general pediatrics, family practice, pathology, 75% of us will be sued.
So all of
So I
us.
look at those numbers and I think nobody's low risk.
Yeah.
No one's low risk, right? If 3 out of 4 are experiencing it, it's not low risk. So, so that sort of really cemented my desire to pursue this topic and to find ways to stimulate communication in the physician community around this topic and find ways to provide people with support in a sense that they're not alone. Because I think most people who go through it, particularly if it's the first time they're going through it, they actually have no idea who among their colleagues has had this experience and they feel completely isolated.
And part of it is because we're told that we're not allowed to talk about the details of the case, right? And that, of course, I guess makes sense legally, but certainly does not help us talk about the actual emotional component of it. So people
Right.
just choose not to talk about it. I mean, I guess for probably a variety of reasons. Maybe we're embarrassed, maybe we're scared. I don't know, but I mean, I'm sure you've talked to a lot of people who are going through this process. Talk to us a little bit about how they tell you about how they're doing emotionally and how this can lead to depression and anxiety, or even my guess is my even suicidality.
Right. Well, I think you're right. I think, first of all, there's a whole known vocabulary that I didn't previously know, but I now know exists around the experience I had when the patient died and the experience, the healing experience, the trajectory that I had to traverse to heal. And we call that the experience of the second victim. So there's a vocabulary for that, and it involves a lot of very powerful emotions, uh, from feeling ashamed, feeling guilty, feeling afraid, feeling sad. That can absolutely be associated with depression, anxiety, PTSD. So now, I just want to ask you a question, Heather. My Facebook notifications keep pinging. Can you hear those
No,
or no?
no.
Okay, good. All right, then I'm going to ignore them. All right. So there's this whole spectrum of emotions around. And then we have the spectrum of emotions around litigation, which I think are two separate stories that interlock and affect each other, right? And make for greater intensity for us. And I think there's some of the same emotions, but it throws in questions around not only do I feel guilty, and I think it throws in shame again because we end up so isolated. I think it throws in questions, maybe second victim does too, but it throws in questions around, am I actually in the right profession? Am I up to snuff? Am I as good as my colleagues?
Yeah.
Do I really belong here? And I think both experiences raise the question of, am I safe in this world that I so strongly identify with? Am I safe in the pediatric ER, right?
Yeah.
For me. So I think that's the mix of emotions. And you can imagine where if you took that mix of emotions and then you tell a person, you must not connect to others around this. You really must deal with it privately. You must deal with it alone. That's just a very toxic soup. So I think certainly there are people who believe that connects to addiction because you start to perhaps try to assuage your fear and anxiety with alcohol, with other substances, right? I could see how it would be so easy.
Yeah.
And I think, yes, there are clear indications that it is linked, at least in some cases, to suicide in physicians.
Yeah. So, what is your advice that people do when they get the news that they are being sued? What is the first thing we need to do?
The first thing to manage the legal process, or the first thing to take care of yourself, or a little bit of both?
Let's talk about managing ourselves.
Okay. So managing ourselves. I think the first step I would take, if you're hearing this, then you're going to hear me say that you probably feel ashamed. And Brene Brown, expert in shame, has said that the cure for shame, or the healthiest approach to shame, is to look for a way to connect with someone who has earned the right to hear your story. So I think you can be very selective, but you've got to find someone or someones to talk to. Mm-hmm. In general, the legal system protects certain kinds of conversations. Certainly protects your conversations with your own physician and your conversations with your lawyer, but there's lots of evidence that also conversations with a spouse are protected. And I think probably another close family member, not everyone's married, another close family member, that would be protected. It's very appropriate to talk to whoever your supervisor is or your medical chief of staff, if that's someone that you trust, mm-hmm. right? You need to ask yourself, do I trust this person to treat me kindly in this situation? Mm-hmm. And then I think there are also opportunities to seek support from someone, be it a colleague or someone like me, in such a way that you don't amplify your legal risk. So what a plaintiff's lawyer, the reason why a defense lawyer tells you to talk to no one is that they're worried that that someone you talk with will be subpoenaed, mm-hmm. and will come in and say something that is not favorable to your defense. That's your defense lawyer's worry, right? So I think it's appropriate to find a safe context to talk to someone about your emotions and your concerns and your stress level and how you take care of yourself without having to talk about the detailed medical specifics of the case or
Yeah.
the details of the protected conversation you've had with your lawyer. Does
Yeah.
that make sense?
Yeah.
So when we
Definitely.
say don't talk about the case, we're talking about don't talk about the medical specifics of the case.
Hmm.
Now, there are other places to have protected conversations that can review the medical specifics of the case, and that would be like morbidity and mortality conference,
Hmm.
a root cause analysis, any type of QI or QA process affiliated with your hospital. That is also protected. So
Okay.
that's the place to explore, the issues surrounding medical practice.
Yeah. Okay. That's good. Because I can imagine, I mean, it would be one of the things that makes you feel ashamed, right? Is that did I do the same thing everyone else would do? What did I do wrong? Those details of that medical case are going to be something that we have to work through as well. And so it's good to know that the M&Ms and the QI process is something that we can go through as well, because I can just imagine, I mean, we all have cases that didn't go well, whether we got sued out of them or not. I mean, that's medicine, that's life, right? People die, people get sick. Sometimes we can't do anything about it. Sometimes we may have made mistakes,
Right,
right? And it's hard not to just think about those things all the time. So,
right,
yeah.
right. I think we owe it to our patients when things don't go well to see what we can learn from it, right? I
Yeah.
mean, that is the story of medicine. That's how we learn. And
Yeah.
that's true for all of us.
Yeah.
And so that's part of the healing process as well, I think.
Sure. Yeah.
So, yeah.
So tell us a little bit about Thrive and what you're doing besides education, and how we can, how that's unique, and how those of us watching can utilize you.
So I think what's unique is that I've seen people potentially out there offering coaching or that kind of thing to help people with litigation stress management, but I'm trying to bring a little bit something different to the table, a little bit more of who I am and what I learned through the second victim experience, and to tie it a little bit more closely to the whole of our lives as physicians, right? Or other healers. I mean, dentists and psychologists, they also get sued, right? So looking at how this fits into our whole lives. I started with some public speaking, which I continue to do, and that is a pleasure to me and very touching to me to see how people respond to that. Then I got into blogging about 8 months ago, and that's been a really beautiful experience because it's connecting me with people all over the country. I get interesting emails that inspire me going forward. What I'm building now is a coaching practice. I'd like to provide people with the opportunity to have one-on-one conversations as they're working their way through their experience. And that might be around their experience as a second victim. It might be around managing their stress through litigation, or a mix of the two. I think many people going through litigation need a mix of the two. So,
Mm-hmm.
but you will have people who have a second victim experience they're having trouble processing, who never get sued. And you'll have people who are litigated against who really have no question about whether they did the right thing and they're not a second victim,
Yeah.
right? But for
Yeah.
many people, it's a mix. Um, and then the other thing that I look forward to doing, which I've only begun to explore, is creating some sort of retreats that provide people with an opportunity to come together and heal together in smaller groups. I'm not thinking of a retreat with 100 attendees. I'm thinking of something involving maybe 20 attendees
Yeah.
and one other faculty person, and really provide an opportunity for conversation and for some recovery in a group setting. Because I think there's just something very powerful in understanding that people just like me people who are great physicians practicing in excellent environments have these experiences over the course of their career, right?
Yeah. Yeah.
So I discovered at some point in the not very distant past a quote by Hippocrates that we all recognize the beginning of it, I think. It says something like, um, life is short, art is long. And then it goes on to say, experience is judgment difficult. And I thought, wow, to use the word treacherous to
Yeah.
describe clinical experience, that's pretty potent. So it tells us that Hippocrates understood this too, right?
Yeah.
That we all have the opportunity to be there. Whether
Yeah.
we all experience this or not, it can happen to us.
I think one
So
of the things that's important for us to be honest about with kind of, so, my big thing is I want to pull physicians together, right? So that we're more of a community. We try to heal ourselves as a community, try to fix our healthcare system that way. But I also want to pull
yeah,
patients and physicians together so that we just understand each other more. And I think one of the important things that we talk about with our patients is not just we're real people, and real people come with personalities and skill sets and ups and downs, right? But also to talk
right,
about how treacherous that healthcare decision making is, right? That like every second there is a decision being made. And with every decision,
right,
there's a possibility that decision is being made um, on incomplete information, or because because my phone pinged while someone said something to me and I didn't hear it, or the 20 other things that are going on in the emergency department or in the operating room or wherever we are. And for people to understand that we're not perfect and that this is all a changing landscape, I think is really important for patients to understand as well. I don't know how we go about having those conversations besides things like this, right? I don't have time to talk to
right,
every one of my
right.
25 patients I'm going to see tonight about that topic, right? But
That's right. That's
yeah,
right. That's
yeah,
right. But I think you're exactly right. I think people who do not work in that sort of an environment may have a hard time envisioning um, that we really do operate with incomplete information. I mean, if for no other reason than that, I think we will always operate with incomplete information around the function of the human body. And then, even if we did have a complete understanding of the human body, any one human body can differ from the quote unquote normal in ways that we cannot see from the outside, or even that an MRI isn't going to show us, right?
right,
Then you throw in the fact that the patient, for whatever reason, with perfect goodwill, still may not provide us with all the information that goes before,
right.
right? We
Or they
may
may know
not pick
how
up on
to.
every bit that they provide us. I mean, there are just so many potential gaps.
Yeah,
And then sometimes things are moving very fast and we're forced to make decisions quickly.
yeah,
So I think that's right. And in fact, the literature on second victims says that to be a second victim, there are two factors. One is you're committed to the welfare of others, and the other is that you're making potentially rapid fire decisions in the face of incomplete information and significant unknowns. So what you're driving at is very true. I think it's a fundamental piece of how this happens to us.
yeah, yeah. That's interesting. Um,
Yeah.
so I please put in the comments a link to that New England Journal article that you said was so powerful for you. That would be really great. If you could do that so
Okay.
people can look at that. And then, any other resources that you have on how people can find you. And why don't you say right now how people can find and follow you online, social media, and your blog?
Sure. My website is www.thrivephysician, all one word, .com.
Perfect.
And on Twitter, I am at Thrive Physician. On Facebook, you can find me at Thrive Inside Education Support. Um, and those are the only social media outlets I'm on. But if you come to my website, You can sign up to receive my blog updates. I'd love to have you there. There's also an easy way to email me through the website. There's a contact page. And I'm always very happy to hear from people in regard to your personal experiences or their needs around these issues.
Yeah,
So,
that's great. Put some links to those in the comments as well. It
okay.
was really lovely to see you in person. We've been following each other on social media for a long time. So thanks so much for
Yeah.
all of that support and for everything that you're doing. I think this is really an essential topic and it's certainly a great service to your physician community to be providing that kind of coaching. So thank you so much. And you have a lovely Medical Monday.
Yeah, thank you, Heather. Thanks so much for having me.
Yep, take care. Bye.